So I think we'll make a start. Welcome everybody to this the seventh in our series, the learning event series for the reconditioning games. Penultimate one, actually, one more left. The next one in 2 weeks' time. Really delighted to welcome our guests to the session today, Jenny and Julie. I'll give a quick introduction in a moment. Just really glad and pleased that they're able to sort of carve out time in their really busy diaries to come and join us this afternoon. I know it's going to be really fascinating and interesting to hear from both of them. We are recording this session, so we will make it available to you afterwards. If anybody who can't join it, please share that with them. We've got a chat room is open, and Lucy, my colleague there, is looking after that for us. What we'll do, we'll hear from Jenny and then we'll hear from Julie, and we'll have questions towards the end if that's okay. So please post any questions you have through in the chat, or just wait until the end and pop your hand up, and then we can put those to our guests. Sometimes any comments or thoughts as well in the chat is also helpful for our speakers as well. We can just respond to those if need be. So we're going to hear from Jenny Keene first. So Jenny is the Director of Intermediate Care and Rehabilitation. Jenny joined NHS England in December 2021 as Director of Intermediate Care and Rehabilitation in the Community Health Services National Team. Prior to joining NHS England, Jenny was Chief Allied Health Professions Officer at the Department of Health in Northern Ireland. A qualified radiographer by background, Jenny was appointed as an Allied Health Professions Consultant in the Public Health Agency in 2012. She's held a number of board-level appointments, including Department of Health Management Board for Rebuilding Health and Social Care Services, the Joint Department of Health, Department of Communities Housing in the Health Board, and the Northern Ireland Primary Healthcare Board. So lots of experience in this area. So I'm really grateful for Jenny and her time today. So I'm going to hand over. I've got control of the slides, Jenny. So just please let us know whenever you need me to move on the slides. But over to you.
Thank you very much, Nick, and good afternoon, everybody. I'm absolutely delighted to have been asked to speak with you this afternoon, because I've been following this initiative over the last year, 18 months or so, and it's one that I'm really passionate about, and I can see the benefits when I go out to do system visits in the areas that have really taken up the reconditioning agenda. What I hope to do today is, or in the next 20 minutes or so, is explain to you a little bit about the national priority in terms of future policy direction across this area, and the work that I'm leading here at NHS England. And to go back a step, I like I said, really interested and have a long sort of career history working across community health and the wider rehabilitation agenda, including rehabilitation in hospitals. And it's been a frustration or a challenge across all of those agendas to make deconditioning or rehabilitation or all of that agenda become business as usual, and to become core delivery components across health and social care. So what I'm going to do in a lot of my presentation is talk about the UEC recovery plan and the wider intermediate care programme, because that's the vehicle, or the lever, I will sometimes call it the Trojan horse, of what I am hoping to use nationally to bring deconditioning and rehabilitation into the core business as usual, and onto the top tables, and so that it is given its rightful place as part of those main discussions. So I use a phrase that, supporting people to live their best lives, which is what I think this agenda does. It actually makes sure that everybody, regardless of age, ability, etc., is supported to live their best life. Increasingly with senior decision makers, whether they be political or exec leaders here, I've started to break that down further to say what I am about on this agenda is being able to support people to walk, talk, eat, drink, sleep, and participate in life. And who doesn't want that for themselves, their families, or their communities? So I try to demystify the wider rehabilitation agenda and break it down like that. I'm going to now talk, if I move on to the next slide, please, Nick, a little bit about how I'm taking that agenda forward within the national priorities and sort of the big policy areas. So really important that I can describe and articulate what the problem that we're trying to solve and why I think the wider intermediate care approach is a solution to that. So tonight it's actually now nearly over 13,000 people that will spend the night in an acute hospital instead of a more appropriate place. The majority of those people are in hospital because of delays in accessing post-discharge services in the community. In other words, recovery, rehabilitation, rehab, the ability to actually support them to be able to participate in life. And the transformation of out-of-hospital services is one of the key elements of the NHS recovery plan. And then intermediate care plays a key part in that. Going to take the time to just talk through what intermediate care is, and it's a set of short-term multidisciplinary services and interventions organised either through health and social care to support people in their own homes or in community, bed-based or non-bed-based, after discharge from hospital, and at those at risk of hospital admission. And it underpins the principle that people recover best at home. Next slide, please. So the UEC recovery plan, and I always, when I come on to the UEC recovery plan piece, feel like I need to say to people, well, why is that community agenda, rehabilitation agenda, home first agenda sitting in the wider UEC recovery plan? Why is it docked in there as opposed to primary care or community care? And it's back to the, not quite the Trojan horse, but in some ways a little bit of the Trojan horse, that with all of the work that we've done around discharge, what we've realised, well, some of us have always realised or known it, is that, you know, discharge is a symptom of a system that's not flowing. And it's not necessarily that we have a discharge problem, but we have a capacity and capability issue with across community services. So to actually get the front door working, we need to get the back door working, and that step down bit. So the recovery plan has 5 key areas of action: increasing capacity, that's investing, this is the wider UEC piece now, investing in more beds and ambulances, but also making better use of existing capacity, improving flow. That means not having people sitting and lying in beds if they don't need to be, growing the workforce, increasing the size of the workforce, working to strengthen discharge process, investment in step up and step down health and social care, and we have a new metric for measuring that. Expanding healthcare outside of hospitals, stepping up capacity in out-of-hospital care, including virtual wards and better support for people at home, and then making it easier to access the right care. Next slide, please. Key areas of focus for me at the moment are transfer of care discharge hubs. That's ensuring that people have access and are matched to the right capacity and services that they need when they are ready to leave hospital. And a big part of that work is working with people earlier on in the process so that they don't actually decondition, so that you actually start a discharge process and that flow bit right from the start. Joining up with social care through the Better Care Fund and scaling up with intermediate care. I should have also said at the outset, one of my key drivers is that I don't think people should be in hospital. And I think people should be in hospital for the shortest length of time they possibly can be. And that step down capacity and out of hospital services are only effective if they're timely, because a lot of harm comes from people deconditioning while in hospital. And I'm often not sure whether it's the intervention or the timeliness of the intervention that has the biggest impact. Next slide, please. So scaling up of intermediate care, what are we wanting to do? So we began a programme of work about a year ago to develop and pilot new approaches. We've got 6 national discharge frontrunners. They've been supported, signed off and supported by the Prime Minister, supported across the Department of Health, the Department of Levelling Up and NHS England. So they're very high profile, have a lot of political interest. They include piloting new solutions to intermediate care, discharge and flow, including reablement and wraparound care. 3 of the front runners have a focus on a new community recovery service, which is all about preventing deconditioning and improving and increasing rehab capacity. And NHS England is also undertaking intensive work with a number of other areas or a number of other pilot sites. One of the pilot sites is actually really focusing in hospital on dementia care, and it's really about it's a really strong deconditioning initiative. So it's about actually not having any of these people in beds at all. So it's actually, one of them is the Oasis unit up in Manchester, absolutely fabulous. And I've actually taken a lot of learning from it that I think should be applied across all wards, not just dementia wards. The initial learning from these sites is going to be available. It's available this month. We're just working on it at the moment. Big part of that learning is the actually prevent the deconditioning, get the rehab going quicker, don't allow people into that inactive phase. And then by autumn, we'll have developed a new planning framework with national standards for rapid discharge into intermediate care. And we're looking at a next day 24-hour sort of national standard for that. Because like I said, I think it's that, and that for me is the deconditioning agenda. It's actually getting people rehabbed active in a timely way. No point waiting for 6 weeks when people have lost that ability. Next slide, please. So the front runners, like I've referenced, there's a national task force that goes across a number of the key government agencies and a number of external stakeholders, and it's a real focus on integration and intermediate care, and it's looking for new sustainable ways of delivering these services. The other thing that's really probably worth saying at this point is this really links to the white paper integration agenda, because if we can get this right at this rehabilitation, step down, integration across health and care right, it's a real litmus test for the effectiveness of what we're looking for within the integration white paper. So the front runners, we've got the integrated intermediate care front runners. Those are Croydon, Leeds and Warwickshire. They're testing the community recovery service for us. We're also got a front runners doing integrated data and digital, and they're looking at the tools they're looking at are very much around developing information governance and joint data sharing agreements across health and local authorities to be able to understand that recovery rehab service requirement at that interface. And then, like I said, there's one mental health one, which is up in Manchester, that's looking at dementia, and actually it is effectively preventing deconditioning and supporting rehab for people with dementia. And I have to say, it's when you speak to them, it's one of those projects that it reminds you about why you come to work every day. It really is. It's good for you to just to spend time with them. Next slide, please. So what we want to do with the expansion of step down care, I'm going to go to what the objectives are, because I think that is what's important. We want to reduce the length of stay of people in hospital. And yes, that is an NHS England objective, because they want to, improve, scaling up of or restarting of elective care, increasing productivity of elective care, saving beds, getting people through. But the real hearts and minds and the real reason why we're doing the reducing the length of stay is because staying in a hospital bed when you don't need to be there causes you harm. You do not need to be in a hospital bed if you don't need to be. And this agenda goes while people are in beds as well, getting them more active up and out and around in that piece. Decreasing long-term care costs by decreasing demand, because we're actually recovering and rehabilitating people properly and on timely. And the evidence suggests that then ongoing care is reduced. It's quite sad when you see the number of people that go to residential and care homes that you question if they had actually been rehabbed on time and not had that deconditioning, whether we would have that burden going on to adults, into long-term care, and then increase the number of people receiving rehab and recovery services. Okay, next slide, please. See, folks, I have to check myself here that I don't go off on an agenda. You'll have noticed I'm very good at flying off on a particular tangent. So I did reference, and I should always remember, we have a published commitment that we're going to have a planning framework for the step down service available for systems by autumn. The things which we need to have in this framework, which will be going out to systems, are how to increase rehabilitation capacity and access across all systems, across health and care, improve capacity and demand planning, in other words, that the demand coming out of hospital, that there is sufficient capacity to meet that in a timely way. And we move away from the idea of spot purchasing beds, putting people into care home beds, etc. So building up that capacity to recover people at home and in the appropriate settings. Utilise current funding sources, and a lot of that is about aligning some of the resource that's possibly in acute into community, some of the spot purchase money going towards more active recovery. Develop integrated governance for oversight. It's an easy one to say, a really difficult one to realise, and pre-winter access to effective care transfer hubs. Data, because we're very weak on it, particularly across community and in this space. And then improve intermediate care services with a focus on continuous learning. So we need to set up a community of learning across both health and care and the voluntary sector to take the good practice. And then that's this bit. So next slide, please. So like I said, and I'm bringing this up because it can feel like we're boiling the oceans at times. So we're trying really hard to almost develop a service that has been a Cinderella service for years, and there's very little infrastructure in community or within rehabilitation services to do this. So we've tasked ourselves with having some really key deliverables. A model of care, which is about a model of community rehabilitation. So how can we increase community rehabilitation and in-hospital rehabilitation for frail elderly people, and provide a framework to the system, creating the right capacity. So that's about the services that are available. That's a big workforce issue as well. And we're doing a lot of work around skill mix, expansion of non-registered workforce, access to apprenticeships, utilising professions that we haven't previously utilised, so exercise physicians, utilising the staff that are in gyms, everything. So we're really trying to, extend and widen the scope of the workforce that we're talking about here, and bring those into the core commissioning and planning of services. Funding and affordability, well, I wouldn't be on here from NHS England unless I actually put a nod to that. And then organising to deliver. What that actually means is, what are the structures that we don't have at the moment across health and care in England to be able to deliver a service like this? We don't have the leadership. We very rarely have this type of work reporting directly to corporate boards. It's not being referenced, counted, managed in sort of routine. As I said at the start, business as usual. This needs to become as important as the number of pre-assessments that are booked in a day, the number of cancelled theatre slots, etc. So it's trying to get it up onto that level. And how will we know it's working? Back to the reduction in length of stay in hospital, more people having good functional outcomes, and driving down the demand into long-term care. Next slide, please. I think expand, have I covered? No, yes, you can go through the next two actually, because virtual wards I'm not going to cover, and I'm not going to cover this either. And I think I've kept my time. I did go through really quickly, but I really would like some questions or some comments, or if anybody has anything to add, I would really like to hear from you.
Thank you, Jenny. I know you've rattled through that really quickly, just conscious of our time. I know that's been really appreciated. I think one of the sort of few points I just wanted to draw out really, I think, is this Trojan horse approach. You talked about this Trojan horse, sometimes you just have to find a way within existing context to find the things that we're passionate about, and sometimes it isn't always about banging a particular drum. It's about finding the right. I think you touched on that really well, and that Trojan horse, but recognizing that there are lots of things, and we may not always think this sits in the acute sector or around discharge, but if that's where the attention is, sometimes we just have to play those games, unfortunately, if that's probably the wrong phraseology.
It's not the wrong phraseology, Nick. I can actually recall at a recent interview being asked what my leadership style was, and saying I think I'm a chameleon, because I actually will mold and shape the agenda to where it needs to fit. And I think we do have to do that. At the moment, it has landed squarely, in probably the most high profile agenda item that we have at the moment, and that's why it's getting traction. There is a pragmatic realism in terms of it needs to be at that table to get funding, to get priority, and more importantly, workforce. To get the workforce planning in behind it, it really needs to be a high priority.
Yeah, absolutely. There's a few questions coming in. We're going to hold them until the end, so we can because some of the questions may go across both speakers. I think there's I think we've started to hear a few stories now around some incidental stories of the impact of reconditioning activity on reduction in length of stay, or reduction in the degree of care package allocation, and those are we're starting to get a sense of that. And I think that's where we can bring that forward and bring the power of this work to the fore. And it's really what I find fascinating about your run through there is how it's connecting to a lot of the national work at a very high level, and how we can start to see the connections at a very local level, and the things that we see in our the therapists and the staff nurses and the activity coordinators at a very local level. There's a very natural thread that leads all the way through to work that's happening at a very national level as well. So it's been really fascinating to see that. So thank you for that.
No, you're really welcome, and I'll go through the comments or the questions, and then I'll take more at the end if there's time. Thank you.
Thanks, Jenny. So I'm going to bring Julie in. So first met Julie Robinson. Julie Robinson is the Chief Executive of Move It or Lose It, and this is an organisation that I stumbled across really from a friend of mine who's I think on the call, Claire Walsgrove on the call, who introduced me to Julie. I just thought it was a fascinating example of how we are connecting now with organisations beyond traditional health and social care. We were talking just about how some things are centred around the acute or the hospitals. We've always wanted this to be broader than that, through community services, through social care, but also through third sector, charity organisations, and other organisations that are providing services out there that we may just not know about. And that's how I learned about Julie, and I was just fascinated after I started stalking her on Twitter and looking at the work that they're doing. Just fascinated on the approach, and how it's all really connected to reconditioning, keeping mobile, keeping active, encouraging people to stay active, but also not just from the physical activity, but from the social side, from the mental stimulation, from the mental health perspective, from these things that are all unintended consequences, but wonderful in terms of reducing loneliness and connecting people with other people. And I think Move It or Lose It for me was a really great example of that. So I wanted to bring Julie along. So Julie, over to you. I'm gonna challenge you again. I know you have your challenges with Apple compatibility with Teams. So I know you're going to share. I've got the slides here if you need them, but over to you if you want to go ahead.
Thank you very much, Nick. Can you see my presentation?
I can.
Wonderful. And thank you so much for inviting me to come and join you today, because just listening to everything Jenny said and having spoken to Nick and Claire on the call, it's just wonderful that we can play a small part in this excellent initiative and the campaign to recondition the nation. So I want to run through what Move It or Lose It is, how it fits in with what you're doing, and some of the resources we have that are freely available that just might be helpful to you out there. So Move It or Lose It really began when I was a PE teacher. I hate saying that because half of you will already hate me. But it was all about, throughout my life and career, trying to help people be more active and find fun in movement, whether that was from primary school, secondary school, actually through a dance club in the 80s when it was Jane Fonda, and I loved the leg warmers, and aerobics came fashionable. But really, when I, about 15 years ago, retrained to teach exercise to older people, found that there was something magical and almost miraculous about bringing people together to exercise, to socialise, and watch how they can completely transform their life. Transform ageing, I suppose, sums it all up. So on to the next slide, please, Nick. So what we aim to do, I'll run through some of the things as we go through the slides, but as you can see, we're very much about trying to keep people active, not just physically, but socially, cognitively, emotionally. And undercurrent of all of this is to prevent deconditioning. And I'll be sharing some evaluations to show how surprising results have been for even frailer older people who you would not expect to see such improvements in. So on to the next slide, please. We like to make all of our classes, whether they're in community or care, fun. So when I first began, I was teaching classes, couldn't keep up with the demand, and actually everyone said the same thing. Can't remember what to do when I go home. So after many drawings and stick men and trying to give them things that they could follow at home, I made a DVD with the people in my classes, and they came up with the name, Move It or Lose It. They said, don't use the word exercise, it puts everybody off. I made a DVD, met with Professor Janet Law, Director for the Centre for Healthy Ageing Research at University of Birmingham, and she encouraged me to continue. We made 5 DVDs to try and work from chair-based through to more active, looking at falls prevention, for example, as well. A book that was for people who don't have DVD players, and making sure that we include resistance training as well in all of what we do. On to the next slide. So we became collaborating partners with the university, but what I really wanted to do was make sure that it wasn't just helping people at home, but that if it could be replicated with what I was doing in my small area in the community, by training others to do that too. So we've developed the FABS training program that incorporates flexibility, aerobics, balance and strength. It also includes games and activities, and it's done with music, and it can be done seated and standing. So we can really reach a wide variety of people that tend to not exercise, people that don't go to the gym, that are struggling to go for long walks, for example, can absolutely do an hour's class and improve. And I'll be showing you how that can be done. So this is now a nationally accredited and endorsed training programme. We reach around 25,000 older people every week in the church hall, the community centre, the care home. So it's open to everybody to join. Next slide, please. So always we needed to underpin this with evaluation and proof, evidence that it's working. And the very first project we did with the university was a small project with some really frailer older people in Burton. And we found by using the SPPB, looking at their timed up and go, looking at their sit to stand, whether we could actually see an improvement. And within the 12-week programme, these are the results that we saw. So seeing that almost everybody improved their sit to stand, their ability to get out of a chair unaided, is absolutely key. That's getting on and off the loo, maintaining independence, and of course with that leg strength all the other things can follow, as Jenny was saying, supporting people to live their best lives. That's what it's all about. On to the next slide, please. So the Royal Voluntary Service, many of you will know from their work in hospitals pre-pandemic and home from hospital now as well, were looking to partner with an organisation to help people stay independent and look at elements of physical activity and strength and resistance training. But they do work with a lot of frailer older people, a lot of people with dementia. So over 12 months, they did an independent evaluation and they found that, again, between 10 and 14 weeks in various locations, that all of the findings were showing that the chair-based exercises in this instance were so particularly effective for preventing deconditioning, reducing that loss of muscle, preventing frailty. But they also found that it was incredibly helpful at tackling loneliness And of course, we know that the knock-on from that can be fantastic in terms of improvements in mental health. Next slide, please. So we've continued to work with Royal Voluntary Service and trained hundreds of their volunteers to make sure that everybody embeds activity when they're having a cup of tea and a chat with someone through to the day centre. So it's a great way of making sure that we keep that movement as part of their treatment, as part of their everyday life. All of the exercises we do relate to an activity of daily living. And that's where the motivation is then intrinsic to that person, because they don't care about getting stronger quads, but they do want to know about being able to get up the stairs or walk the dog or do the gardening. And we were invited by the NHS, this is in Birmingham, before the Birmingham CCGs merged. And it ran for 3.5 years really successfully. Were classes for people with COPD, with breathlessness, who are incredibly difficult to reach when it comes to physical activity. And the doctors and the nurses were helping to get people along to classes in the GP surgery. Small groups of up to 12 people with a 12-week course. And that also included the cup of tea and a biscuit afterwards, which is obviously the way to everybody's heart. But during those chats, we were using it for education in a very subtle way to talk about other things, looking at falls prevention, looking at hydration, nutrition, medication, using their inhalers properly, and developing that rapport and communicating with people who come in feeling very scared and worried, and finish the 12 weeks going, I can't stop now, this has changed my life. And as you can see here, again, looking at the timed up and go, we actually had at this point something called a Q-tug, which is a device that can measure frailty and falls risk. So we get really objective data from that. And as you can see, the improvements were staggering, but it was also, as the doctors were very keen to know, how did it make them feel? And we get lots of anecdotal evidence and lovely videos. If you ever want to look on our YouTube channel, will make you smile. Next slide, please. We also worked on a falls prevention with ROSPA. This was the Stand Up, Stay Up 3-year project about preventing the first fall. And again, we used the Q-tug, this quantitative timed up and go with the sit to stands, which is, you know, absolutely key for our research, and looking at how these improvements were helping people to just sometimes improve their confidence around their balance and talk about better balance. They all had a DVD or a book and a resistance band, and they were given homework, so they weren't just doing one class a week. And again, the results were outstanding. And it just shows how you can work with people from a range of background of ability levels. The average age, they're usually in their 70s, 80s, but we do work with people in their 90s and 100s as well. But what we see, wherever we deliver this and however it is delivered, everybody is showing these improvements. They may be small in some, they may be massive in others, but it shows everybody has that capacity to try and maintain that muscle, to try and improve their confidence, to try and increase their levels of activity, so that, you know, like Joan puts the kitchen timer on, so she gets up and walks upstairs or round the kitchen every half an hour when she's knitting, because otherwise you suddenly realise you spent hours in your chair. Next slide, please. And that's why we have the cuppa routine. This is on YouTube. It's 4 simple exercises you can do in the time it takes to boil a kettle. And we were asked actually for a way of trying to get people to remember to do this. Clicking the kettle on is the trigger, but we've got a tea towel with it on as well. And we've had some NHS trusts getting these for social prescribing purposes, just something that's going to remind people that they can empower themselves to be active at home as well. We can be prehab, we can be rehab. But that cuppa routine, we've got a PDF. If you just want to print out, please get in touch. You can have that and any of our resources that we can give you. Next slide. Please, Nick. During the pandemic, all our classes stopped. It was horrendous for everybody, of course, and working with a vulnerable group of people, we were desperate to try and find ways to keep people active. With some funding from Sport England and the National Lottery, we set up an online club, and it's still running now. It was really to try and give a sense of community again. So it isn't just exercises, there's a book club, a monthly cuppa and a chat, there's cookery and there's art and there's other things happening. It's been brilliant to have there. We know it doesn't replace the physical get together, and not everybody can do it because they're not online, but for those that could, it's been an absolute lifeline. Now it's free for a month and it's $4.99 a month after that. So it's quite cost effective in terms of someone can literally join every single day whenever they want. And what we found was really good here was it was helping carers, people who can't get out to classes. It was helping people who live in rural locations who can't get to a class because they're too isolated. And it also appealed to people who like to exercise in their pyjamas in the kitchen and nobody can watch them. On to the next slide, please. So we were doing work with Royal Voluntary Service, and in Morecambe Bay, they were starting to teach the exercises, the chair-based ones, so really making sure that no one was put at risk of a fall. And they actually worked on the wards and worked with over 4,500 patients, which of course we were just delighted about how that was working. Everything stopped with the pandemic, and sadly there's been a long gap, but that's why we're so excited that we've been able to reignite this again just recently with Claire and with Nick. If you can go on to the next slide, please. We had to try and make those exercises that we were doing and Royal Voluntary Service were doing on the wards and with one-to-one. We have an app called Get Up and Go, but we've literally, since chatting with Nick a few months ago, we've made these available on YouTube. Now, these were filmed in in situ next door to the Queen Elizabeth Hospital in Birmingham, University Hospital Birmingham, in a hospital bed, in a hospital chair. So they're very, very simple exercises. These are just to help people get up, get dressed, get moving, that NPJ paralysis. But the exercises could be just shoulder rolls. They're flexing the feet to help put your slippers on. They're just turning the head very slightly to improve mobility. So again, de-risking it. It doesn't need a physiotherapist there. As long as they've been told that they're safe to do this and participate, then absolutely great. They're on our YouTube. That link, if we share the presentation afterwards, will take you to it, or get in touch with us. We'd love to think that more people are accessing these if it's appropriate. On to the next slide, please. And that's where we come to you. And we've worked then with Claire to train 14 people in Telford and Shrewsbury NHS Trust. And we were at Telford College just over the last 3 weeks, training 14 people who are going to work on a one-to-one basis with their patients. Who rather than just being with them and helping with care and trying to chat with them and so on, is that they're going to be doing the reconditioning games. They did the chair-based exercise course, so it was full on 2 days, warm up, a little cardiovascular, very much about mobilizing, stretching, circulation boosters, and some strengthening exercises, using a band if appropriate, ball if not, anything that's going to help people to get up, get dressed and get moving. So they went through 2 really full-on days, and they were just at the end of their 3 weeks of training in this new role. And on to the next slide, please. And everyone was delighted. They got their uniforms and they're ready to start, just started this week. And of course, that's going to be evaluated to see how is this going to work? How can this be embedded to prevent deconditioning. And I've got on the next slide, we hope, a little video. You can see them enjoying some of the games that we were trialling.
Just talk through this, Julie, as they talk to the different activities.
So as you can see, this is the training room where they've been doing other training. But we were looking at, as well as strengthening exercises and stretches and mobilisers, is the games and activities don't feel or look like exercise. This is a particularly tricky one because it tests out the coordination. So actually, everybody, it's a shame you can't hear because there's an awful lot of laughter going on. But what we looked at was how to adapt so that they go away with a big toolkit of things they can pull out with that particular person that might help them just realise that they can do something to help themselves. And by doing these little things, it could just be cognitive, it could be physical, it could be both, a little skill. But a lot of fun is the way that we can embed movement to prevent deconditioning and recondition the nation. My email address is there, and please do get in touch, and I look forward to your questions. Thank you.
Perfect. Thank you, Julie. I think what was really fascinating about that, and it's like, as we're starting to now see some evaluation, some evidence, and we've got Dahlia helping Matthews on the call as well today, and I know, so have a look at Dahlia's comments in the chat as well. These are just further reinforcement of the reasons why we're doing this. You know, we're starting to see numbers now that back up the importance of this. Sometimes, you know, we find that when we're busy and we think we haven't got time for some of these activities because other things are taking priorities, we're now seeing actually some numbers that sit behind why this is so important. So both from Move It or Lose It and Dance for Health, which is Dahlia's work, got some really great evaluation from from Sheffield Hallam University, which is fun. And we're going to record, myself and Dahlia are going to record a podcast on that as well. So we'll share that with the group as well once we've got that recorded, which will be all around that work. Just shows the impact of this particular work. So thank you for that, Julie, and thank you, Jenny. I'm going to throw over to Lucy. Any comments or questions in the chat?
Yes, there's been loads of discussion in the chat and some people sharing some really great work that they're doing elsewhere as well. So thank you so much. Emily and Natalia were asking Julie, do you have any leaflets that they can share with patients for post-discharge?
Yes, I think the best thing is if they email me at julie@moveitoрлoseit.co.uk, or you can just go on the website and it'll be forwarded to me, and I'll have a chat with them to see what they're looking for, and we'll look at what resource might be the best. There are things people can print out for themselves, people that we have printed and can send. So yeah, do get in touch.
Thank you so much, Julie. And then also a question from me. So this is really interesting, really exciting stuff that you're doing. It's incredible that the level of reach that you've achieved. So I had two questions actually. One was around how have you managed to achieve such a broad reach? Is it through word of mouth, or have you gone through other routes? And the other one is also, oh sorry.
No. I think I mean it's been a real struggle because typically using social media is the way everybody promotes their activity. You know, if you consider traditional keep fit and exercise, but for our audience it's much more word of mouth. We say it's for everybody who attends a class, their first class is free, come and try it, and it is about them then speaking to others. But all of the instructors across the whole of the UK, they go out into their community and talk to their people. But what we'd love, and it is starting to work better now, is having that automatic link through the social prescribers, because then it just makes it easy for people instead of having to search for something, not being sure if it's appropriate. And at least then they have the phone number of the instructor, they can phone them up, have a chat. Is this okay for me to come? And give them that little bit of reassurance. The biggest hurdle is getting them through the door in the first place. Once we've got them, you know, I've still got people from my first class 15 years ago who are now 94 and still coming to the class because they love it. So that's what we'd like to have.
Well, it's real testament to you that the programme has managed to achieve such reach through word of mouth, and I totally recognise that some of the population that you're aiming for, actually virtual communication, social platforms might not be the route. So my other question kind of links into that, which is around your virtual classes, because I think it's amazing that you're providing an option for people who aren't able to attend in person, and makes it much more accessible. But also I wondered, like, how has the uptake of that been, considering some of those people might not have access to technology?
Yeah, I think that was our biggest frustration, was that we'd got something that could be so helpful, and yet lots of people just hadn't got the capacity to be able to get online. I think when we'd gone into like a second lockdown, more families, if they're lucky enough to have a relative, particularly somebody young who comes in and shows gran or granddad how to use it, for example, more people were used to going on Zoom, but there was still a huge confidence crisis. We've teamed up with the Good Things Foundation in terms of trying to help promote digital inclusion, simple training for people. But we still know that after the pandemic, when people could go back to classes, they prefer to do that. But we have still got the club there for those that find it helpful.
Thank you so much for sharing, Julie. There's one other question from Dahlia on the chat as well. She's asking how your programme's funded.
Yeah, so everything has been funded through just well, it is actually a limited company, but it's run like a charity. So, you know, in the first 6 years, I didn't take a salary because I just knew how this could transform people's lives. Where we have had funding is things like Transform Ageing, which we did in Cornwall and Devon to help those in the rural communities. And then we've had funding from Sport England for, say, the online club. But really, it is down to just dogged hard work, getting the word out, and bit by bit growing our team, our instructors, who are, half of them are aged over 50. Most of them are retired. In that they absolutely love what they do, and they're passionate people who are going out there into their community to reach people.
Thank you so much, Julie.
Thanks both. Jenny, I think you picked up quite a few of the comments yourself in the chat. Was there anything you particularly wanted to pick up on? Any of the comments?
No, except that what Julie has described is exactly what we're trying to increase capacity for in terms of the model of care. So it aligns really, really well. So I think, Julie, there is the potential, you know, as we start to roll out a model of care, we will likely be looking for, you know, we'll be directing systems to look favourably on services that similar to those that you're providing, so that it's not actually, as you say, always you need. The line we use is therapy led, but not necessarily delivered. So as you described, so long as you have the assessment that a programme is safe for a particular person, it can then be delivered by somebody else. And I think that is how we will increase, you know, access to that type of deconditioning and rehab, you know, across and utilise particularly our therapists where we really need that expertise. But yeah, I found it it was enlightening. I really enjoyed it. And I'm going to ask the Deputy Director for Rehab here to link with you and see if we can actually just even use yours as a good example. And I'm going to do the same with the dance one that was outlined in the chat as well, because we need to sort of almost create a directory of those type of services.
Thank you. Brilliant. That's really helpful, because I think this is what when I first met Julian, and then I met Dahlia as well. It's knowing that that's out there. Sometimes these guys are doing some really great work, and often it's hidden and we don't realise it. And I know that both organisations are connected to healthcare in some ways, but not in that sometimes that very obvious way. Claire's been waiting very patiently with her hand up. I'll come to you.
Thank Thank you. So not a question really, just more some feedback. So our staff have thoroughly enjoyed the training course that they did with you, Julie, and the impact that we're seeing already. So they're going out, it's our enhanced care team that's a new team. They're working individually with patients that need more support in hospital. But the other staff now are observing them carrying out those activities with patients, the joy that it's bringing to the patients, but also the staff that are working on the wards is fantastic. And I'm hoping that that will just spread further now across the wards. So yeah, thank you very much, Julie. I feel so fortunate to have met you via Twitter and made contact.
Thank you. Me too. It's been a breath of fresh air to work with you, Claire and Nick, and Dr. Amit Arora as well. Thank you so much for coming to speak at our conference. So yeah, we're really just so thrilled to be part of this wonderful campaign and programme.
So I'll bring Dr. Arora in. I know he's on his travels to, I think he's probably in the airport, either landed in Belfast or just about to take off to go to Belfast. But just give him a heads up that I'm going to come to him in a minute. Just in terms of some of the essence and what we're trying to achieve here. Of course, reconditioning is at the heart of it, but we want to bring a sense of joy as well to the work. And you know, it's been difficult recently. It is still difficult, and what we are seeing some examples of teams enjoying the work that they're doing and feeling a sense of purpose and a sense of achievement, and not just doing the transactional things that you just have to do every day, but actually feeling like you can be a bit more creative and get some enthusiasm and joy in this. And that's all been about what we're trying to achieve here as well. So great feedback, so thank you for that. Dr. Arora, any thoughts, comments from yourself?
It's just been absolutely brilliant to hear so many different people of huge caliber over the last few learning events, and this one has been absolutely wonderful and so dear to my heart. And thanks, Jenny, for all the insights that you've given and all the work that you've been doing. And same for Julie. I think, Julie, we've been kind of fan of yours for a while now, and it will be absolutely lovely to come and speak at your meeting. But also huge thanks for what you're doing. So colleagues, it's been absolutely amazing experience running the program to recondition the nation, and I'm ever so grateful to all of those who have been doing this work, who have been participating in this work, and those who have been facilitating this. So keep it up. Thank you,
Amit. And I'm just going to assure everybody, I think Amit's in the back seat of the car, not the front seat of the car driving. He's multi-talented, but even Dr. Arora can't drive and take a team call at the same time. So this brings this one to a close. Thank you very much to everybody who's joined today. Thanks to Jenny, thanks to Julie for your comments and thoughts and wisdom that you bring to the room. Hugely appreciated. Our next and final learning event is on the 3rd of May. We're joined by Professor Adam Gordon, who's the president of the British Geriatric Society, and he's joined by Kate Tantam and Lou Galley from Plymouth, and they're all about their Rehab Legends campaign. So have a look at #RehabLegends on Twitter. You'll be amazed at some of their work that they're doing. So please do try and join us for that one, same time, 3rd of May. But for now, enjoy the rest of your afternoon. Have a pleasant day and good week, and we'll see you at the next session. Thanks a lot for your time.